I'm Joseph Choucroun from France, and today I would like to share with you the last updates of osteoimmunology and oxidative stress. We have different types of failures: failure in osseointegration, failure after osseointegration, and failure after bone graft. When we ask the literature, we don't have clear answers. Combined factor, multitudes of factors. And then the question is, bone loss, is it a fatality? We have another question. When we have a fracture of tibia, it takes around 6 weeks to heal and to be load. And when we do a bone augmentation, we need to wait 3 to 9 months to place implants and to wait again 3 months for loading. We need to go back to the science. During 400 years, we were following the osteology science, the communication between the bone cells. But this concept is closed since 2000, when Aaron and Choi published about osteoimmunology, showing that the bone cells, they communicate through the immune system. What is osteoimmunology? Osseointegration starts by an immune reaction, means the release of inflammatory cytokines. But these cytokines induce inflammation and angiogenesis. We need to remind that the amount of new vessels depends on the immune system. The immune system plays an important role in bone formation, and the bone resorption is regulated by the immune system. What is the immune system? We have the cells. We know them, the white cells, the hematopoietic stem cells. We have proteins, interleukins, antibodies, TNF. What is the immune reaction? It's the inflammation. But we have a very important information to know today, that this inflammation must be brief, maximum of 5 days. When we start inflammation, we have the first period, which is the first 5 days. We name it the short-term inflammation, and during these 5 days, this inflammation is beneficial. And this is why we heal and recover. However, after the 5th day, we start the long-term inflammation or chronic inflammation. And when we stay with inflammation after the 5th day, this inflammation becomes harmful. The effect is inverse, and it becomes a negative inflammation. Why the long-term inflammation is harmful? Because the long-term release of interleukins will increase the production of the oxidant. We know that these free radicals are unstable and toxic, and this is why our cells start to produce antioxidant in order to neutralize this oxidant. It means that if we want to be healthy, we need to have a balance between oxidant and antioxidants. But sometimes we produce too much oxidant, or we don't produce enough antioxidant. And we name this situation oxidative stress. Oxidative stress leads to major cells issue. DNA, cells membrane, immune cells are damaged. And then the wound healing is delayed and the immunity is deficient. This is why we will make higher rate of failures or complication. From now, you must know that if you have a failure, a complication, an infection, it's because there is too much oxidant production, induced by a significant or chronic inflammatory situation. We can take the example of diabetic and smokers. We know that this patient, they are meeting more complications simply because they are in oxidative stress. Diabetes, hyperglycemia induces oxidative stress. Diabetes is a chronic inflammatory disease, and diabetics are deficient in vitamin D. What is the issue with the smoker? The smoke breaks down the antioxidant in the gum, in the lung, in the skin. And this is why they meet more cancers in the lung. But the smokers are also deficient in vitamin D. The increase of oxidant in osteoblasts is the critical component of the pathophysiology of the bone loss. And then this situation induces an immune deficiency leading to an osteoblast inhibition and osteoclast activation. The result is a failure of the bone remodeling. We lose the bone because the bone remodeling fades. Long-term inflammatory situation will induce through the rankle a differentiation of the macrophages in osteoclast. But what we know since a few months is that the osteoclasts, they can release also inflammatory cytokines. And then we can say that osteoclasts are immune cells. And then we are going to a persistent inflammation and a continuous resorption. The bone loss mechanism is only the remodeling failure induced by oxidation. We can take a simple example. When we extract a tooth, we will meet a lack of mechanical activity. And in this situation, the bones start to produce much more oxidant. And this bone oxidation will lead to failure of remodeling, and this is why the ridge resolves. This is the same mechanism in the space. We have osteoporosis inducing by lack of pressure, means by increased oxidation of the bone. So now we see the situation. Oxidative stress induces immune deficiency. And then the infection is facilitated. And we understand why the infection is coming only after 6 or 7 days. Because after the 5th days, the immunity collapses and then the infection starts. Resorption is promoted because inhibition of osteoblast and activation of osteoclast. And fibrosis starts. We understand why now we meet sometimes fibrointegration, because the inflammation around the implant or into the bone graft stays too much time. Oxidative stress occurs when we don't have enough antioxidant, deficiency in vitamin D, smoking, or when we produce too much oxidant and we have the high level of cholesterol, the chronic inflammatory disease, a long-term contamination, the foreign body reaction, and during a long-term ischemia. In pre-op, we must assess the level of oxidative stress with these 2 blood markers, the LDL cholesterol and the vitamin D. This paper was the first published into the whole field. We did it with several famous opinion leaders in order to inform the dentist that they need to take care about the level, the serum level of cholesterol, LDL, and the vitamin D. We have 2 kinds of cholesterol, HDL and LDL. Why the HDL is good? Because it's an antioxidant. And why the LDL is bad because it's an oxidant, inducing oxidation of the osteoblast, leading to a slow bone metabolism, and we see that the bone is replaced by fat. The bone turns yellow. When you raise the flap, you see that the bone has a yellowish color. Brandmark, more than 35 years ago, he was teaching the student, when I see a yellow bone, I cancel the graft. Why? I don't know why, but what I know is that I'm meeting too much failures. Vitamin D, we know how to produce by sun exposure, or if we take oral vitamin D, and then this vitamin D moves to the blood with the first pathway through the liver and the kidney, producing an active hormone. Vitamin D is an hormone active on the calcium metabolism. But we have the second pathway, which is named the paracrine activity, leading to anti-inflammation and antioxidant production. We are today more interested by the immune function of the vitamin D, and this is how we can improve the wound healing. A lot of people are deficient. 70 to 90% of the world population is deficient. The question is why? Because at the beginning of the humanity, humans were living naked, taking sun every day, the whole day. And this is how we are living today. Clothes, caps, bird, glasses. We don't have enough skin exposed to the sun in order to produce enough vitamin D. We know that some people are systematically deficient: elderly, dark skin, obese people, smokers, diabetics. And when we lose the bone around implant, the first question is to test the serum level. Cholesterol is high, vitamin D is low. Cholesterol is high, LDL, cholesterol, and vitamin D is very low. I'm getting several questions by dentists why I'm meeting successive failures in osseointegration. Because the cholesterol is too high, the vitamin D is not enough. We are meeting failed implant because the vitamin D is too much low. This lady is spitting implants one by one. But when we test the serum, we see that the cholesterol is too high and the vitamin D is really too low. Recently, we got this information that below 20 nanogram, vitamin D deficiency has a causative role in the systemic inflammation. And we see that below 20 nanogram, the CRP, the C-reactive protein, is increasing too much. How to supplement? If we want to prevent skeletal abnormality, we can give 400 to 600 units a day in order to achieve the normal serum level, which is 30 nanogram. But as I told you, today we want to improve the immune system. And then we need to give them 10 to 20 times more. 4,000 to 10,000 in order to achieve the ideal serum level, which is 50 to 70 nanogram per milliliter. Immediately you will ask me, do this dose is excessive? I will tell you no. Until 10,000 units a day, it's normal in human physiology. What does it mean? It means that if during the summer you go to the beach and you stay the whole day in the beach, exposed to the sun, you will produce 20,000 units. It means that when we supplement with 10,000, it's not excessive. This is Leo. I'm grandfather since a few weeks, but she's taking 2,000 units a day since her birth. It's not my prescription. It's the prescription from the pediatric field. 2,000 units a day, even if she's only 4 kilo weight. What is the protocol? First, we test all the patient. We never start a surgery without testing the patient. But as we want to achieve a high level, we supplement all of them because we want to achieve a high level of serum vitamin D. We must start at least 1 week before the surgery because we need time to start to produce enough antioxidants. And we have two kinds of patient without risk factors and patient with risk factors. We know them now: elderly, diabetic, smokers, dark skin, immune disease. We give them 2,000 to 4,000 for normal patient and 5,000 to 10,000 for risky patient during at least 3 months. But when you make a diagnosis of deficiency, you will give to the patient a simple message. You must continue during your whole life the supplementation with 2,000 in the first case and 5,000 in the second case. Now we can explain most complications. First, allergy to penicillin. We know that this patient, they have an increased risk of surgical site infection. They have higher rate of failures. Why? First, because allergy is a dysfunction of the immune system. Responsible is the T lymphocyte, and this lymphocyte, they release too much inflammatory cytokines, and then they produce too much oxidant. But the second reason is that allergic are deficient in vitamin D. Then they don't produce enough antioxidants. And we can say that these patients are in oxidative stress, and this is why they will make more infection or meet more failures. Resorption and fibrosis after bone augmentation. Sometimes after bone augmentation, we see resorption or fibrosis. The issue is that the biotub is thin, and then the bacteria, they can penetrate and spread to the periodontium, inducing a chronic periodontal inflammation. And we know what happens when we have a long-term inflammation. We will meet fibrosis or resorption or both. When you see an inflammation, it means that the gum in front of this area were inflammatory. When we do a bone augmentation, even with autogenous bone, if the soft tissue is inflammatory, it will induce resorption in the underlying bone. The foreign body reaction. We know that all foreign body, they induce immune reaction because we have the T lymphocytes. This is the immune reaction. And then this foreign body reaction depends on the compatibility. If the material is compatible, highly compatible, the inflammation will be low and short. But if the material is low compatible, it will induce a long-term inflammation and oxidation with a delayed osseointegration, with fibrosis, with connective tissue production. If you want to use a compatible material, the best is the human material, autogenous or allogenic. But close to human, there is a porcine, because the antigenic structure is very close to human. And then we will not see any inflammation, then not any oxidation, and we will not see any giant cells in histology. If we use other materials, equine, bovine, synthetic, we will see inflammation or oxidation. How the bone oxidation occurs when we have a long-term ischemia. From Mamoto and this paper published in Nature, we know that if we leave tension off or we apply pressure, we will lose the vessels. And then we can take a simple example. If we see a bad ulcers, it's because the pressure was too long on the skin. When we press too much the skin starts to be in necrosis. Tension induces ischemia, and then oxidation and bone loss. When we lose bone around implant, it's because there is a lack of vestibule, and we know that bone loss follows the chronic tension. We can induce oxidation when we place an implant with unreasonable pressure, means inadapted torque. And then we should reconsider the primary stability. First, we need to go back to the bone physiology. We know the Wolff's law. The bone remodeling depends on the mechanical activity. What is the mechanical activity? This physiological stimulation is cyclical. But when we place an implant, we apply a permanent pressure. And we can ask the question, do the implant placement is contradictory to the physiology? We have a second law, which is the Hooke's law. Hooke is the father of all the engineers, and he published this law since a while. A material reacts to pressure according to its density. When the material is soft, there is no stress. When the material is strong, there is a high stress and the material will break. So if we have a cancellous bone, then the implant placement will meet a flexible bone and there is no stress. If the bone is rigid, like cortical bone, then the stress is very high. Implant placement will create high pressure on the cortical bone, which has no plasticity, poor blood supply, and then it will induce bone oxidation on this cortical zone. This is why we are meeting the margin bone loss. If the cortical is sick, we will meet a quatrain because the cortical does not support any pressure. When you place the implant in the cancellous bone, you can expect a long-term stability over time. When you place the implant in cortical bone, in only a short period, you will see the damage. If we analyze this X-ray, we see that we have 4 perimplantitis, but we can say that the resorption takes place always in the cortical bone. So before implant placement, we need to assess the cortical thickness. If the implant is in cancellous, you can place with high torque and you can load it immediately. But if the implant is placed in a full cortical zone, then we cannot place with high torque and we cannot make an immediate loading. When we place implant in bone graft, we make 2 mistakes. The first is believing that bone graft must be very dense. And we place the implant with high torque because we believe that the stability is important. We must remind that bone graft is not flexible and behaves as cortical bone. Any compression of bone graft will be fatal to the bone. Osteoimmunology. All pieces now of the puzzle are in place. We know that the bone tissue remodels because we have the two mechanisms, osteogenesis following osteoclastogenesis. But if we want to meet the normal remodeling, we need antioxidant. And with the antioxidant, you will get the immunity. And with the immunity, you will get the vessels. It's very simple. But if you leave pressure or tension, you will lose those vessels. If you want to increase the antioxidant, you can use a vitamin D, you can use immune supplement, and you can use the PRF. In order to do not induce any immune reaction, we need to use compatible biomaterials. And we need to have enough gum thickness. So now we can propose solutions. First is to reinforce the patient immunity. Vitamin D is critical. We need to supplement in vitamin D, but we can also add other immune supplements in order to shorten the inflammation and to increase the antioxidant production. This is why I designed the Immune Force, which is an immunity pack with 13 molecules that have the only one function is to improve the immune system. We can use the autophagy. Autophagy by Ozumi, he got the Nobel Prize in 2016 because of his publication. What is autophagy? When the cells are in fast, they organize cell cleaning and eliminate all the unwanted substance, including oxygen. It means that when the cells are in fast, they do a physiological detox. How to induce autophagy? Simply by intermittent fasting. We need to be in fast 16 to 18 hours in a day. It means that we must miss the breakfast and we must take the dinner before 8 p.m. My protocol for intermittent fasting is around 10 days, 5 days before surgery and 5 days after surgery. But you will see that the patient will tell you that they appreciate this situation and they will continue this kind of intermittent fasting. We can shorten the inflammation by steroids. This is why they are beneficial. But we need to give them only one dose, it's enough. Pre-op means 1 hour before. Prednisolone, 1 milligram per kilo, or dexamethasone injectable, 0.2 milligram per kilo. We can use antibiotics with immune function. 40 years ago, Kudo published the first paper about immunomodulation function of macrolides. And during the COVID, we had a large use of azithromycin. But the question is, why to use azithromycin in the COVID? COVID is a virus, and then antibiotics are not active. And my conclusion was, azithromycin has a huge immunomodulatory function. And I said, at the first opportunity, I will start to use azithromycin. And then after the lockdown, a case was made with a vertical augmentation. The patient was allergic to penicillin, and after 6 days, we met a monumental infection, pus, inflammation, swelling. And then I proposed to the surgeon to just give him 2 days of azithromycin, 3 pills a day, 2 days only, with the help of vitamin D, and then let's go to control the patient after 2 days. If the infection is still there, we will use the bisturi in order to open and to clean. But the surprise was that after 2 days, there is no sign of abscess. And the patient met a full recovery in 1 week. And this is the reopening at 3 months, full success of the bone augmentation. It was the first time in my life that I met an abscess healing naturally and spontaneously after use of one antibiotic. And then we started to get publication after August 2020. All of this paper, they show that azithromycin induces immunomodulation and inhibits oxidative stress. But one of the interesting information is when we give azithromycin, 1 dose is active for 1 week. And then the treatment is very simple. Obviously, we do not forget to give vitamin D and to be helped by the immune supplementation. When we do simple case of implant or GBR, we give to the patient 1 single dose of azithromycin, 1 gram. It's enough the night before. When we do big augmentation, we use 2 single doses, 1 of azithromycin the night before and 3 grams of amoxicillin 1 hour before. And that's it. However, I told you in the beginning that when the biotype is thin, the bacteria, they penetrate into the periodontium. Or when we have an inflammatory soft tissue, we have a risk of resorption. And then we will give them azithromycin 1 gram weekly during 2 to 4 weeks. This treatment of repeated dose of azithromycin has a goal to reduce the long-term periodontium inflammation. What the gum loves most, azithromycin powder on the sticky bone. Then we can control a patient after full arch implantation, and we see that at D4, the inflammation is gone. There is no sign of inflammation. It means that the healing is complete. When we do extraction, even in an inflammatory site, we do a huge bone augmentation, we can see that only after 3 days, we got already the full recovery. So we need also to talk about the pressure on the crestal bone. I told you that in the cortical zone or in the graft, we don't have a flexible bone. And then we need to prevent the margin bone loss by using always the countersink in order to make an over-drilling. We need to separate definitely the implant from the cortical bone in the first 2 millimeters, or to place the implant subcrestal or both. We must shorten the inflammation into the bone graft. How it occurs? First, by the mobility of the granules. And this mobility induces the fragmentation of the bone callus, which occurs after only a few days. And then if we want to fix the bone, we can use the sausage, means the membrane with pins. or we can use the sticky bone made with PRF. The second is the foreign body reaction. We use a foreign material, and I told you that the best choice is the human bone because it doesn't induce any inflammation. But the issue with the human bone is the volume loss all the time, the fast resorption. And this is why we started to use the mix of human and xeno, mostly bovine. But the bovine is too much inflammatory. And we may move to a porcine xeno in order to do not induce any inflammation. Porcine xenograft will allow us to do not meet any immunoreaction, and it will give us the volume maintenance. We don't need to mix the porcine xenograft to human. It has a good porosity, the best compatibility, and a fast angiogenesis. But if you use a bovine, you must mix with human, but inflammation still stays. Other solution is to use PRF. We have a huge evidence about the benefit of PRF. But at the beginning, when I designed the PRF, I used the P and the F. The F is coming from the fibrin, and fibrin is a tissue matrix. And this is why I gave this name. What is the concept of a tissue matrix? In this case, for example, we don't have vestibule, and then we want to make a vestibuloplasty, making the incision, the split incision, fixing the flap to the periosteum, but instead of connective tissue graft, we will use the fibrin. And this fibrin will be transformed in a gum in only 1 week. Today, we have the evidence that PRF induced angiogenesis, reduce the inflammation, reduce the inflammatory cytokines. And then we can say that PRF is an antioxidant, and it enhances the local immunity. Is there any interest to use a swing rotor bucket? Means if we use an horizontal centrifugation. Almost the whole centrifuge are angulated. Only 2% are doing an horizontal centrifugation. And following this paper published by Miron, he claims that he is increasing the amount of cells with a 10-fold increase. Nobody can believe in this concept. Just by changing the angle, we can increase 10 times the amount of cells. Only idiots can believe in this concept. But if we want enough time, the literature will come to say that there is no change in the amount of cells when we do an horizontal centrifugation. And then, is there any interest? I will tell you no. If we have a strong immunity, if we use the matrix, the fibrin matrix, then the open wound is possible without fear of infection. We leave open the site and we can get the bone because the immune system is working well. Without biomaterials, this is what we will meet. A good bone stability in the vertical dimension, a better keratinized tissue. What else? But we can do socket preservation with biomaterials, mostly with sticky bone. We put the bone graft and then we use the patch, the fibrin patch, to close the site. This is the open wound technique. And this is, for example, 3 sockets grafted with bone, graft with porcine xenopurgo, and we see the behavior of the gum coming to close spontaneously the site. But look at the amount of keratinized tissue and the amount of bone after only 4 months. When we cannot close the site, we just need to use a compatible material and to organize the closure with the fibrin. We will get the perfect healing. When we place an implant and we graft the gap, we may use the fibrin as a poncho in order to fill the gap between the implant and the soft tissue, and then to increase the amount of keratinized tissue. When we want to increase the soft tissue, we can leave open. And then between the two edges, which tissue is growing? The keratinized tissue. This is how we can improve the outcome. When we place the PRF, we see that the gum will come to close the site and to give us enough keratinization. So what is one of the last update is the pump pack. The pump pack is the technology that reduces the temperature in the blood in the tube, and then we can increase the amount of the fibrin into the PRF clot. Today, with the pump pack technology, we have much bigger clots. But one of the most important updates is the sticky bone, because we want to get any granule surrounded by fibrin, and only after 1 minute we will make the gel, a gel with the bone graft, and then we can shape, squeeze, design exactly the bone graft that we want to use. We can make a very strong sticky bone. When we want to make a bone graft position, we use 1 piece of sticky bone. It's enough. So simple, no granules, no any granule surrounding the bone graft. We can make the sandwich technique using the graft with the gel and the layer of fibrin. And then we can prepare one sole piece to apply in the full maxilla. This is the sticky bone that we apply in 1 shot. We have now the palm swing. We need only a few seconds to produce a sticky bone. This is the Sticky Bone Express. How to enhance the biotype? This is a good question when we do implant, because we know that we need to improve the thickness of the soft tissue. We can improve with the PRF liquid, injecting the papilla and improving the volume of the papilla. We can increase the healing of the soft tissue by injecting the PRF liquid before opening the site. In this case, it's a full perimplantitis. And then, after placing implant, making a bone augmentation, we can see how the bone reacts, the soft tissue reacts. In only 1 week, we see a full healing of the soft tissue. But we can increase the biotype by increasing the soft tissue blood supply. How to do that? I want to show you a case, the first case of vestibuloplasty we made with PRF. We opened the site at the mucogingival line in a split incision, covering the gap with the PRF and getting much more soft tissue. It means that we can make a conclusion. if we want to improve the soft tissue, we need just to give more blood supply to the soft tissue. But usually the bone is getting the blood supply from the soft tissue. And when we place implant with enough ridge thickness, we cannot expect to get blood supply from the bone. But if we graft on this ridge and cover with PRF, we can improve the soft tissue. What is the concept of the overflow? We place a bone graft, and this bone will be a trabecular bone. What do we have into the trabecular bone? We have the bone marrow, and this bone marrow will supply the soft tissue in vessels. And this is how we can increase the gum thickness. You see that all of these ridges are enough thick, but it's not enough for us. We will do a massive augmentation and cover with PRF. And then we can see what happens. Even when we have a vertical bone loss, we can rebuild the whole bone volume, getting the bone papilla between the implants. You see that we have all the bone papilla present between each implant. But if we get the bone papilla, we will get the gum papilla. This is the kind of soft tissue we meet when we do overgraft in the maxilla or in the mandible. Just a few cases to show you how we improve the soft tissue and look at the quality of the aesthetic outcome. Look how we change the biotype by using this concept. Look how the soft tissue is improved. Even when we have a thin soft tissue, we see that we are getting a lot of keratinization and obviously a very nice aesthetic outcome. When the soft tissue is thin, we can improve it just by a bone augmentation, systematic bone augmentation. This is few cases of full arch rehabilitation with the concept of the vascular overflow. If you do not a bone augmentation, you will not increase the soft tissue thickness. So now the question is, can we reduce the time of the bone formation? We apply since many, many years the over concept. I designed this concept with my friend Jérôme and Alain Simon-Pierry. What do? We do everything that biology likes, but too much. We over-supplement. We use over-compatible material. We over-release the flap in order to do not have any tension. We over-drill in order to do not have any pressure on cortical bone. We overgraft, you understand why. We overstimulate with PRF. And then we can see few cases. Only 2.5 months are enough to get a full bone formation, but we can do less in only 2 months. We can go to 6 weeks. And then we can say that we are at the same position than the biology. Then we can say that the bone formation is almost physiological. When we do a bone augmentation, we don't need to wait more than 2 months. When we do a vertical bone augmentation in the mandible, we don't need to wait more than 2 months to get a full bone formation. In a vertical bone augmentation, we just need to wait 7 weeks to achieve a full bone formation. You will ask me about histology, biopsy. Yes, we have this case with a huge perimplantitis, making a full bone augmentation with the concept of the fast system, using the sticky bone with Purgo, and then we can see the follow-up at only 4 months. We didn't use any collagen membrane, and we can get the full bone formation. And then the question is, can we do biopsies? Yes, we did 2, one in the anterior zone, it's the horizontal bone augmentation, and one in the posterior zone, which is the vertical bone augmentation. In horizontal bone augmentation, we got only 20% connective tissue. In vertical bone augmentation, we got only 10% connective tissue. So the question is, now we can explain that when we do a bone augmentation, the stem cells coming from the vessels, they will produce osteoblasts, and the osteoblasts, they will produce the bone matrix. However, if the site is inflammatory by contamination or foreign body reaction, then the stem cell, they will produce fat, connective tissue, and fibrosis. So if you want to prevent the connective tissue growth, you need to reduce the inflammation, shorter time, and we need to give to the patient an immune supplementation. And if we want to immobilize and to reduce the space between the granules, we can use the sticky bone or the sausage thickener or both, as you want. So now the question is, what is the function of a membrane? Doesn't matter collagen or PTFE. It's an immune barrier to avoid spread of inflammatory cells and cytokines coming from the soft tissue or from the bone graft itself, because the graft is inflammatory. So now we can design the indication of the membranes. We have 4 situations. First, 2 situations where we use an inflammatory graft, which means no human, no porcine. And then we see that it depends on the gum. But in the 2 situations, we see inflammatory cells and cytokines spreading everywhere. And this is why it's logic to use a barrier. When we use a non-inflammatory graft, means human or porcine, we meet the same situation. Inflammatory gum or non-inflammatory gum. When we have an inflammatory gum, cells and cytokines will spread from the soft tissue. And then it's logic to put a barrier. But if we don't have inflammation in the gum or in the bone, PRF membrane is enough to protect the bone and to stimulate the bone formation. This is the ratio today of our use of collagen. 1/3 case, soft tissue thin or soft tissue inflammatory, we use a barrier. No inflammation, 2/3 of case, we use only PRF. This is a case with inflammatory gum. We use a membrane, and then we see how the healing is coming. Only 2 months to achieve a bone formation. This is a case of vertical augmentation. The biotype was thin, then we use the collagen membrane, and then at 2 months, we can open to drill in order to place an implant. Look at the aspect of the bone augmentation at only 2 months. So my first conclusion is that immunity is mandatory to shorten the inflammation. We will get the vasculogenesis, we will meet osseointegration, and we will achieve bone maintenance. Conclusion 2, PRF is one piece of the other concept. We cannot trust in the PRF alone. We need to use all the concepts: supplementation, compatibility, drilling, grafting. The third conclusion is that we understand that now that when we have oxidative stress, we will meet immune deficiency and bone loss. And then we can conclude that the periimplantitis is an immune disease. Periimplantitis starts with bone loss, following pressure on bone, following tension in soft tissue. When the patient has chronic inflammation, we know the situation now: diabetics, obese, allergic, smokers, deficiency in vitamin D, immune disease, but also following soft tissue incompetency. What does it mean? Incompetence to avoid bacteria to spread, to penetrate the periodontium. It occurs in thin biotype. What is the population with thin biotype? 1/4 of men, half of women. It means that 1/3 of adults are candidates to periimplantitis if we don't manage the soft tissue around implant. We can go to see few examples. In this case, we achieve all the protocol: no pressure, no tension, controlled biology, overgrafting, and then we achieve an effective periodontium. What happens after 15 years? Nothing. Because we did everything that biology likes. Even after 14 years, there is absolutely no change. Even after 13 years, there is no change. Even after 10 years, there is no change. So my last conclusion is that we can go to Roma by different ways, but the biologic way is the simplest and the fastest. Just to let you know that if you want to know more about osteoimmunology, you can join us at the SciFac Congress held in Nice, south of France, and the topic is only osteoimmunology. Thank you for your attention.